Trying to conceive and feeling overwhelmed and confused with unhelpful information and advice? This podcast is for you. Welcome to Don't Tell Me to Relax. I'm your host, Hannah Pearn, a fertility acupuncturist and passionate advocate for better fertility education and support. Our aim is to empower you with information to support your fertility journey and provide a community for connection with people who get where you're at. If you'd like to join us or work with us in clinic in London or across the UK, all the information is in the show notes at the end.
AcuPips sponsors Don't Tell Me to Relax. If you're looking for a way to naturally balance your body, calm your mind and relieve anxiety, then AcuPips has the answer. AcuPips is the UK's original ear seed company, founded by traditional acupuncturist Zoe Young. Ear seeds are small seeds or metal balls attached to an adhesive and placed on pressure points on the ear in specific combinations, creating balance within the body. We like to call it healing jewellery. Discover more today at acupips.com and use code RELAX for 20% off site-wide. AcuPips. Modern healing, ancient practice.
Hello, it's really lovely to have you here today for this week's episode of Don't Tell Me to Relax. I am joined by Dr. Sami from Plan Your Baby, and we are going to be discussing tests and investigations for miscarriage. So, Dr. Sami, welcome to the show. It's lovely to have you here.
Thank you very much for having me. It's a pleasure to be here. And yes, hopefully we can discuss this important topic that a lot of people are affected by. So yes, I think this is a very good thing to discuss today.
So, can you just tell us a little bit about your background and your work at Plan Your Baby before we start?
Sure. So yes, I've been doing, I've been a gynecologist for 20 odd years now, but I had a special interest in fertility for the last 15 years. And with the fertility does come miscarriage, especially recurrent miscarriage. So I've seen many women who've been through recurrent miscarriage, who've been through different testing in with their GP, with the gynecologist, with the recurrent miscarriage clinics, the specialized clinics that the NHS have. And some of them, they do succeed, of course. Many people will succeed. But some of them sometimes do find that they wish to do further testing, further treatments, which are not currently available through the NHS. So yes, my experience is mostly fertility and miscarriage. And with Plan Your Baby, we are a fairly new clinic. We've been open for about 3 years now, but we are a telehealth clinic, so we don't have a fixed location, which is good because it means that we can reach out to people all over the country. So people in the past, if they didn't live near a big city, London, Birmingham, Manchester, had limited access to more advanced testing, to kind of more experienced supervision. Whereas now we can offer people who live even in more remote areas these tests and the treatments, and we monitor them and supervise them. So this is kind of, I think, the future of medicine is that things are going to be more um, done remotely. It's already happened since COVID. That there's been an explosion in telehealth, and I think this is just going to go further and further.
Yes, I agree. We have so many people who contact us through the podcast about where can they get support from who are, like you say, not based in local cities. So I think there is really is a need for this kind of medicine for people who can't access it in big towns or cities.
Yeah, yeah, and this was our aim when we set up Plan Your Baby. We wanted to kind of give access to these people because otherwise it's very difficult and they have to travel very far and it takes time off work and it's costly. So we want something a lot more convenient and easy.
So, Dr. Sami, can we just start talking? We're going to talk about miscarriage today. So, can we just start around this idea of how many miscarriages or what are the rate of miscarriages that affect people in the UK? And am I right? Have I done my research right that there are no official statistics kept for the number of miscarriages that people experience in the UK each year?
Yes. So first of all, miscarriage, whether it's recurrent or not, there is disagreement on how many miscarriages count as recurrent. In the past, it was mostly accepted that you needed to have 3 consecutive miscarriages to class as a recurrent miscarriage, but now there is more of a trend that once you've had two consecutive miscarriages, it's probably a good time to start investigating and looking for causes because nobody wants to have a third miscarriage if it can be prevented. So this is definitely changing, although still there are many who stick to the three miscarriage rule. Now, miscarriages are very common. People don't always hear about them and sometimes are shocked when they first get a miscarriage. As you get older, unfortunately, there are more errors in the chromosomes of the egg, which can then lead to genetic abnormalities in the embryo. And as a woman gets older, you don't make new eggs, so these eggs will start to have more errors. And therefore, if you look at young women under the age of 30, miscarriage rates are about 10 to 15% of all pregnancy, which is still quite high, actually, higher than what people would think. Then, if you look at women who are 35 to 39, it's about 20 to 25% of pregnancies, so almost a quarter of pregnancies are lost due to miscarriage. Then, once you get to, let's say, 44, it's about 50%, 46, it's 70%, and then once you get to 48, 49, it's about 95 to 99% of pregnancies are going to be lost because of miscarriage. And most of those are chromosome related, so they are related to the genetics of the embryo. But of course, there are other possible causes of miscarriage as well. And it could be something to do with the uterus. So sometimes there is a problem with the uterus itself. Maybe it's a polyp or a fibroid or scarring inside the uterus, especially if someone's had miscarriages and evacuation procedures. Sometimes it's hormonal related. So women who may have blood sugar which isn't controlled well, or thyroid which isn't tightly regulated, or even something like PCOS, polycystic ovarian syndrome, is associated with higher miscarriage rates due to the hormone imbalances that can be derived with that. It can be something to do with clotting, so there may be a slight increase in the clotting tendency for that woman, which can then block off the tiny blood vessels which feed the baby nutrition and oxygen, and that can also be a reason for miscarriage. And sometimes that is linked to autoimmune conditions like antiphospholipid syndrome or lupus. There can be other autoimmune activity which can cause immune attack against the embryo, and that can cause miscarriage as well as infertility. Can be infections sometimes. The microbiome, bacterial vaginosis, is also linked to miscarriage. It can be lifestyle, so definitely women who smoke or who abuse alcohol or have very high intake of caffeine, or these are rare, but things like exposure to heavy metals, radiation, pesticides. If there's high enough exposure, that can also cause miscarriage. And then, yes, men also have a role to play. So the sperm does give 50% of the DNA, but it's not quite a 50% ratio. So with this, it would be less of an effect. When it comes to men and age, we see that the increase in miscarriage starts from the age of a man being 45 years or above, and it's a more gradual decline. So even men in their 60s, so a man who's 65, will be still, the sperm will be having much less impact compared to a woman who's in her 40s, for example, on the risk of miscarriage. So yes, men do have a role to play, but there's a lot more weight with the egg and with the woman.
So, what I'm hearing is that there are many reasons why somebody might experience a miscarriage. But what's interesting is that I hear also that lots of people are told when they have a miscarriage, it's a sad one of those things that happens to women. It's kind of, I wouldn't say brushed off, but I would say, people are told there's nothing that you can do about it. It's one of those things, it's nature's way. And I feel like, given that you've just listed a whole list of reasons that are related to miscarriage, I feel like this kind of idea that there's nothing that you can do is not necessarily a good answer when it comes to how can people prevent this from happening in the future, what role they might be able to play in their future pregnancies.
Yes, that's right, Hannah. So you're absolutely correct. A lot of time it is brushed off and it's said to be just bad luck, etc. Now, I don't want to alarm people. So if someone has had one miscarriage, for example, there's no need to go down the route of lots of investigations and treatments. That's usually bad luck. And, the majority of times, the next pregnancy will go fine without any further treatments or, anything else done differently. But once it starts to happen consecutively, recurrently, I do believe that there should be some investigations offered. And the NHS do offer some investigations, it's true, but sometimes that would cover it, and sometimes, of course, it may not.
So, if a person has suffered a miscarriage and they want to get further investigations, where would you recommend they go first? Do they go to their GP? Do they go to a fertility clinic? Do they go privately? What is the kind of standard procedure for somebody?
So usually people would start off by going through the GP. That's kind of the standard in this country, at least. And the GP will offer, sometimes they'll offer some basic tests. If it is recurrent miscarriage, where there's 3 miscarriages or more, then they may get referred on to the recurrent miscarriage clinic, the NHS one. But they are usually very overbooked, and the waiting list can be a few months. It could even be a year or even 2 in some cases before you get seen. Of course, that's not ideal for someone who's wanting to have a baby now. So it does push a lot of people towards the private sector, where the tests can be done much quicker. You can see something pretty much straight away and get the test done immediately, which, unfortunately, with the NHS, it will be a slower process, and you may have to fight as well to get certain things done. And there is more limitation, let's say, like you said before, due to the costing of many of the tests, there will be more limitations as to what is offered. And my own experience, I did used to do NHS fertility and NHS recurrent miscarriage clinics around 15 years ago plus. And at that time, there were more things offered. We would do routinely chromosome karyotype for both partners. We've had at least 3 miscarriages in a row. That's not done anymore. Even when the genetic tests are done on the miscarriage products with the NHS, what I'm seeing now for some NHS trusts is they won't test the whole complement of chromosomes. So we have 23 pairs of chromosomes, and they would only test 5, 7 most common to cause miscarriage. But that still excludes many other chromosomes which could still cause miscarriage and can cause even recurrent miscarriage, which does irritate me a lot when they then send out a letter saying that your baby was normal when actually they've only tested 5 or 7 chromosomes, so we don't know the true answer. But it's all done to save costs, unfortunately, and that's the situation that the NHS is in, is that the funding is going down and it is becoming more tight.
Yeah. And when you are sent for those tests, can you explain to us what exactly is being tested? So I know there's often a lot of blood tests done. What is it that they're investigating?
Well, there isn't a standard panel. This is kind of more down to the actual clinician as to what they will do. Sometimes you're guided by the history, but with basic tests, then there will be a test usually they'll be testing for hormones. So thyroid function is a standard test. Usually they'll test the hemoglobin A1C, which gives an idea about blood sugar control over the past 3 months. Usually they will do a screen for antiphospholipid syndrome, so anti-cardiolipin antibodies, and antiphospholipid syndrome is not common, but it can be something which can cause actual problems as well as miscarriage for the woman during the pregnancy and for her health. So they usually do test for this one as part of the panel. And they should they should do an ultrasound scan to check for uterine abnormalities, things like polyps or fibroids, which could also cause problems with the pregnancy as well. And I would say that's kind of the basic set of tests that would be offered with the NHS. Sometimes GPs will be good and they will offer all of these that I've mentioned. Sometimes they don't really know and they'll send you on to a gynecologist or even the recurrent miscarriage clinic to do these tests.
So sometimes people do get them through their GP. They don't need to go through a recurrent miscarriage.
It depends on the GP. So some GPs are more clued into this than others. Some don't really understand it very well and they don't know what to do, and they'll just say, okay, I'm going to refer you on to the hospital, to tertiary care. But some GPs, they're good and they do know kind of the basic tests that should be done and they can set them up. Although this is becoming less frequent nowadays, to be honest.
Yeah. I have heard it done a few times by GPs myself. So yeah, but I think the frustration for lots of people is this huge variation of what is accessible. And, again, it comes back to doing telehealth, I guess, is that depending on where you are, how good your GP is, what your recurrent miscarriage clinic is, what the waiting time, there's a huge variation into access and time to get these tests done.
That's true. And this is the story with the NHS, unfortunately, and the waiting lists are getting longer and longer compared to how they used to be in the past.
And so, what about a person who maybe has had two miscarriages? They've had all the blood tests done through the recurrent miscarriage clinic, they've had a transvaginal scan, and they're told everything is normal, carry on, try again. Like, where does that person go with that information?
So this is a common situation, actually, Hannah. And a lot of the time when testing is done, most of the time, in fact, the basic tests come back all clear.
Yeah.
So a person would be then left to try again to get pregnant. And usually they'll be good if they're, three miscarriages, they would offer an early scan to the patient. Two miscarriages, sometimes they'll offer an early scan, which is typically around 7 weeks, just kind of to hopefully reassure the patient that things are looking good at that point. But of course, if there is a cause for recurrent miscarriage which hasn't been picked up, which hasn't been treated, then this isn't enough. It's not going to be the solution for this person. So I would normally, if two miscarriages, I would do the basic tests. There is the option to do further tests. Things like looking at the vaginal microbiome, for example, is a test which nowadays is quite easy to do. It's not too expensive, around £100. You can do the test. It's a tampon that you can just wear at home and post it. And that can sometimes show us that there is an imbalance in the microbiome in the vagina, which then can be treated with probiotics, antibiotics, antifungal. We can tweak the microbiome to put that woman's microbiome in a more favorable state for pregnancy. And sometimes that's a simple step, which there's building research that shows that this can reduce miscarriage rates. Sometimes there are other things that we can test, like the immune system, but that is a much more expensive test and not necessarily essential after two miscarriages. So, we can give the patient the option. But usually for that kind of patient, I would offer some progesterone support as well, where we can monitor the progesterone with some blood tests, HCG, which is the pregnancy hormone, and it can also give an idea in the first 2 weeks of the pregnancy before you can see anything on the scans. And then we can do weekly or every 2 weeks scan from 6 weeks to 12 weeks to also make sure things are looking good and check the progesterone weekly after 6 weeks as well. And giving progesterone is in the form of a pessary, usually in the back passage. And that can be done all the way up to 12 weeks, and then we can ease the patient off it. If everything looks good at 12 weeks, the risk of miscarriage becomes very small, so we can really relax at that point. There is, sometimes something in the history, maybe it's a family history or there's a medical history, which may encourage me also to add in things like aspirin or blood thinning injections as well, or from the blood test that may have been done as well. If it's 3 miscarriages or more, then I would offer the patient blood thinners kind of as an option, even without doing extensive testing, because you can never test all the clotting factors and it's too difficult, it's too expensive. Quite often these people, they will be quite happy to take extra precautions with some extra medication until 12 weeks. And I think that can help sometimes in some situations.
And I think regarding the progesterone, in terms of like NHS guidance into when to use when somebody has experienced miscarriage, am I right in that you have to wait until you've had a scan at around 6 or 7 weeks, you've identified the location and a heartbeat, and at that point you are offered progesterone? Do you follow, am I right with those guidelines, and do you follow those guidelines, or would you bring in progesterone earlier on in a pregnancy?
So it's interesting with progesterone. Until I think it was 2021, there was no recommendation for progesterone at all in early pregnancy, and they didn't actually give it to anyone. But then in 2021, there was a new NICE guideline that came out, which said that for someone who's experienced bleeding in pregnancy, and especially if there's a previous miscarriage, then they recommend taking this progesterone until 16 weeks. And there was a lot of uproar. I remember at the time I was actually talking with some NHS recurrent miscarriage consultants. They didn't like it at all, actually, because it was not what they were used to. So yes, I mean, I think slowly this will change, and there will be more use of progesterone because it is, I think, it's cost effective, rather than allowing someone to have miscarriages and treatment for miscarriages, investigations again and again. Now, in my practice, I don't wait until 6 weeks in the scan, because you may need the progesterone much earlier than that. And why wait till 6 weeks and then find it's too late to start anything? I would start it straight away, a positive pregnancy test, usually, for the patient who would benefit from it, and continue it all the way till 12 weeks, or sometimes 16 weeks, or even 20 weeks, depending on the previous obstetric history. But yes, there's definitely starting to become more acceptance of using progesterone, and some of the recurrent miscarriages NHS clinics are offering it more freely now, even right from positive pregnancy test. I've seen a few of them do that. Not the majority, but I think there is more of a trend towards it, which will change in the next 5 to 10 years, I think.
And can I ask, I know you talked about it briefly before, but can I just ask you to explain a little bit more about this idea that we hear a lot on DNA fragmentation and its links to miscarriage, and why that is not offered as part of exploration, or not that I've seen in recurrent miscarriage clinics or heard of from patients? Why is that not offered or discussed more with patients if we're saying that DNA damage is linked to miscarriage?
So sperm DNA fragmentation is where there would be a proportion of the sperm that have fragmented DNA. So they'll take the man's sperm sample and they analyze the whole sample together, and it gives you a proportion of the sperm which have this fragmentation of the DNA. And it's believed that if the DNA is fragmented, then that sperm isn't going to be good enough sperm to give a healthy pregnancy. Most likely, the woman won't get pregnant if it's very fragmented. It's just not going to make a good embryo at all. Or if there is a pregnancy, then there is going to be a higher risk of miscarriage, of course. Now, it's not a new test. It's been around, I'd say, early 2010, 2011, something like that. I think we started to know about this. And I used to do the test extensively, actually, until about 11, 12 years ago, maybe I stopped. And the reason I stopped is there's not really much you can do about this sperm DNA fragmentation apart from the advice that we give men anyway, which is healthy diet, healthy lifestyle, cut down alcohol, caffeine, smoking, avoid heat, no hot bath, tight underwear, long distance cycling, frequent ejaculation, and taking some male fertility supplements. So we advise this to the men anyway. If we have high fragmentation, that's the recommendation. There's nothing else you can do. And I've seen men with very high fragmentation, and when I used to do tests, 70%, which the normal is 25% or below, 70% or more, and they're having healthy babies. So I think there is also a natural selection that happens, which will reduce the implication of this. So I don't, in my practice, do this test anymore. I think there's been a move away from it. A lot of people that used to do it have stopped. It's definitely not popular in the US. It's something that they kind of laugh a little bit about the Europeans for still doing it, but there's limited use to this test, in my opinion, and I've stopped doing it for a long time. I did many at the beginning, but now I don't do it at all.
Interesting. And can I ask you then, in the same vein, because again, it really causes lots of different opinion, is around the immunology testing and NK cells, steroids, IVIG, intralipids as a treatment for miscarriage, recurrent miscarriage?
Yeah, so some people may have an immune system which is not favorable for pregnancy. And this is a spectrum. There's this whole range where it may be very slight or it may be extremely severe. And the thing with the immune system also, it fluctuates. It's not something constant. So anyone who has an immune condition like asthma or eczema or any kind of immune problem will know that there are times where it flares up and it gets really bad, and then there's times when it's even better and you may not even need much medication or stop the medication. And this would be the same. Now, I don't think there's any doubts as to whether the immune system can cause miscarriage for some people. It's just logic and common sense that this could be an issue, because the baby is a foreign object, and normally there are mechanisms in place which stop the woman's body from reacting against the pregnancy. But of course, just like any system in our body, sometimes these can fail and can lead to either infertility. If it's very severe, you may not even be able to achieve an implantation, or it can be causing recurrent miscarriage. So certainly for people who are having many miscarriages, who are young, and we don't really find any problem, especially, let's say, for example, this woman has had her miscarriage products tested and we found that the chromosomes are okay, and we know that that wasn't the reason. She's a young, fit, healthy woman, all the other tests have come back fine, then I would very much suspect it could be an immune activity which is causing this, and we could do some tests for this, where we look at autoantibodies, antibodies against one's own body, and also natural killer cells, which are a type of white blood cell, and cytokines, which are the protein activators for the immune system. So we can look at these tests. They're advanced tests, they're expensive tests, unfortunately, so it does make it something which not everyone, unfortunately, will access, and is definitely not available through the NHS currently. But for some people, this can be an issue which we can then treat with medication to calm the immune system. And the treatment would vary. It could be something simple, just maybe steroid tablets that you take during the first trimester. That could be enough to calm the immune system sufficiently that your body will accept and keep the pregnancy. It could be that we need to add in stronger medication as well, such as IV drips or other medications as well. But I definitely don't believe this is something for everyone. It's not everyone who will have an immune problem, but if you have had recurrent miscarriages and you're young and there's no other cause, it's something to look into for sure, because it can be a persistent thing. Quite interestingly, there is a subgroup of people who have these immune issues, who some of them will have never had a successful pregnancy, but there will be some who had a baby very easily. First baby came very easy, no problem. Pregnancy was straightforward, everything was great. And then subsequently, either infertility, recurrent IVF failure, or recurrent miscarriage. I do believe that, there was possibly an activation of the immune system with that successful pregnancy, because it is confusing for the body when you have a foreign body inside you, and this can then lead to problems, maybe not so much for that pregnancy, but in future pregnancy, because we do know that things like antibodies take 6 months or more sometimes to form properly. And I don't believe that everyone needs it, and I know it's a controversial topic, and there's different views on this. But I certainly do believe that for some people, this is the key. And I've seen some patients that, without the immune treatment, they never succeeded. And once they had some immune treatment, it worked out really nicely for them.
Yeah, and we see the same in clinic as well. So I'm always keep an open mind about everything, because I feel like the world of fertility medicine changes quite quickly as well, in terms of advancements and changes of thought about treatment. So as a person trying to navigate it, it's really difficult.
It's very difficult. It's very confusing. You read
Yeah.
this, it's completely contradicting this study, and that study's, it's very difficult to know. And this is medicine, especially reproductive medicine, because it's so young.
Yeah.
It takes many, many years for evidence to build and for people to accept things a lot of the time. And when it comes to expensive treatments like immunes, expensive testing, expensive drugs, it's even more difficult to do randomized control style studies, which are the mainstay of how we prove things.
Yeah. And just one last question before we go. I know I'm asking lots of questions, but it's really helpful. Is around, we talked about vaginal microbiome. What about uterine microbiome testing?
So yes, I mean, that's also relevant. The uterus is where the embryo is going to implant, but there are practical difficulties with getting the uterine microbiome. So initially, that's what we used to do. We used to actually do an endometrial biopsy. We used to put quite a rigid, firm plastic tube going through the cervix into the uterus and scraping off cells from the uterine lining to then analyze the microbiome. And initially, this was the only way to do it, and it's very uncomfortable, sometimes extremely painful, and sometimes even the patient doesn't tolerate it at all. So it's definitely not something that you can do again and again. It's more expensive. It costs, probably 5 or 6 times the cost of what it would to do a vaginal microbiome test. And then there's another problem with doing uterine microbiome testing, is that the uterus, when I was a medical student, I was told the uterus has no bacteria, it was sterile. Of course, we know that that's not the case. There is a microbiome. It's a very small mass of bacteria. So, compared to the vagina, there's very, very little of the bacteria, but there is definitely a bacterial environment that we can, consider healthy or not. But because there's so few bacteria there, and because to get to the uterus, you have to go through the vagina to do the sample, it's so easy to get contamination. And because the biomass is very small, when you amplify it, which is how we do the test with PCR, they will amplify the little amount of DNA to get the actual result. It causes a lot of errors, and there's a lot more inaccuracy with doing uterine tests. Now they're trying to develop different ways to do this, and different catheters and things like that. But for now, We stick to the vaginal. It's easier. It's not painful. You can do it repeatedly. You could even do it in pregnancy if you had to. So this is the preferred way, and it does represent, the reproductive tract. You don't forget that the uterus and the vagina, they're not completely sealed off. They are, an open tract. Menses go out, sperm goes in, etc. So this is currently the best way to do it. Maybe in the future will change, but for now, this is what we do: is the vaginal test.
Okay, so thank you so much, Dr. Sami. That's so helpful, because I think it's this idea that miscarriage is something we have no control over is really changing, and I think needs to change more, because I think as women, we are often sidelined and told things because it's nature's way, or that's part of being a woman. And I just think, there's 50% approximately of miscarriages that are not down to chromosomal abnormalities. So therefore, there is something that could be done about it. So knowing that is a really important piece of information that I think sometimes can easily get missed, or is not known widely. So thank you for sharing all of that, because it's really, really helpful. And it's such a huge topic. I know if you're listening, it might feel overwhelming, but I am doing a series about miscarriage over the next few weeks. So there will be more in depth into each of these areas that we have touched on today, because I know it's complex. So thank you very much, Dr. Sami. And I will put all the details about yourself and Plan Your Baby on the show notes. And thanks again for your time today.
That's very fine. Thank you very much for having me, Hannah. It's been a pleasure. And to all your listeners who are having miscarriage, please, don't give up hope. Hopefully your time will come soon.
Thank you. We hope you have found this helpful. If you'd like more on fertility education, please see our Teaching to Conceive free course linked at the end of the show. You'll also find the link to join our community. For more personalised fertility support, you can work with us one-to-one in clinic and online. You can book a discovery call to find out more.